Off-label prescribing. Prescribing a drug for a reason or a population other than it was approved for the FDA can be done within the scope of practice as long as it is with sound reasoning and good evidence. Example, beta blockers, which are usually for hypertension, used for performance anxiety. Often used in pediatrics due to lack of studies and research involving children. Generic versus proprietary. Universal use of generic name for any drug would allow for clear communication and accurate understanding of which drug is being referred to. Generic names are harder to pronounce and remember, but allow for accuracy in understanding what the drug is used for. You may see a difference in bioavailability between the two. Education related to drug use. Teach patients about what the med is for, how to tell if it is working, implications of side effects, interactions with other meds and precautionary measures, specifics on how to take the medication, with or without food, empty stomach, etc., how the drug's effectiveness and safety will be monitored, and provide them with med guides where appropriate. Assessment needed to investigate for different types of drug reactions, specifically an allergic response. Gather a complete medical history, include a detailed med list and current symptoms. Did symptoms exactly the same as before? When did the symptoms start? Did they reappear after restarting the medications? Did they stop when the med was stopped? Does the illness provide an explanation for these symptoms? Are there any other drugs that you're taking that may explain? Allergic reactions mediated by IgE antibodies, or type 1 and Gell and Coombs classification of hypersensitivity reactions. Intensity of allergic reaction is not based on the dose, but the extent of prior sensitization of the immune system. Can range from mild itching to severe rash to anaphylaxis. Risk factors associated with hypersensitivity reactions: females, concurrent illness, previous reaction to related drug, infection with HIV or herpes, asthma, use of beta blockers, use of larger molecule drugs or a combination of smaller molecule drugs with albumin, the route, topical, IM and IV, adult age, genetic polymorphisms. You should identify unbiased sources for prescribing information, such as the FDA Drug Daily Bulletin, or MedWatch, the U.S. Pharmacopoeia, the U.S. Public Service, the PDR, Mosby's Gen X, the American Hospital Formulary, pocket guides. Be wary of a bias. Prevention of med errors. Follow JCAHO's Do Not Use list. For a prescription, put the full name, the street address of the prescriber, and the DEA number. The date the prescription is being written, the full name of the patient, date of birth of the patient, name of the drug, including any special instructions such as extended release, enteric-coated, sustained release, or otic, the strength of the drug in milligrams, mLs, MEQs, etc., the form of the drug such as tablet, capsule, liquid, how to take it, in the signature, which would be the route, the frequency, how long to take it for. If it's PRN, include the frequency, the interval, and the indication. Dispensary. Exactly how many are to be dispensed, the number of refills, and then either mark dispense as written or allow for a generic. Sign the prescription. Pharmacokinetics. In children, overall drug sensitivity in infants from organ system immaturity, including absorption, protein binding, blood-brain barrier, lead exclusion of drugs from CNS, hepatic and renal drug metabolism. Infants at high risk for prolonged and intense drug reaction. Drug elimination is delayed. The doses are higher and longer above the minimal effective concentration than adults. Children less than 1 year. The absorption. Delayed emptying equals increased absorption in the stomach. Delayed absorption in the small intestine. Distribution. Albumin and protein binding limited secondary to low native albumin, and infants' endogenous compounds such as bilirubin and fatty acids are competing for sites. Less binding equals more free drug circulating. This leads to higher dose levels. Protein binding ability normalizes between 10 and 12 months. The blood-brain barrier is also immature. There's increased sensitivity to CNS effects of drugs, so you need to reduce your dose. Hepatic metabolism. Less than 1 year, the liver is very immature, especially the first month. It cannot metabolize drugs, which are mainly eliminated by the liver. You need to reduce your dose. Liver function increases quickly. By 1 year, it is at the adult functioning level. Renal excretion. Renal excretion is low at birth. Renal blood flow, GFR, GF, active tubular secretion are all low functioning. Reduced doses are needed. Again, function is normal by 1 year. Children greater than a year. Pharmacokinetics of drugs are generally the same as adults. The main difference is that children metabolize drugs faster than adults. This peaks at age 2, then slowly declines towards the adult level, sharply declines at puberty. Until then, you may need an increased dose or intervals in hepatic eliminated drugs. The elderly overall have a increased drug sensitivity from organ system degeneration. There is wider individual variation. Absorption. The percent of oral drug medication does not change, but the rate of absorption slows. There is a potential for a delayed drug response. Gastric acidity is lower. It may alter some drugs' absorption. Distribution. 4 main factors are altered, causing an alteration in distribution. There's an increased body fat, a decreased percent of lean body mass, a decrease in the total body water, and a lower concentration of the serum albumin. Increased body fat. This leads to an area for lipid-soluble drugs to sit in storage, which leads to lower serum levels and less response to the drug. Decreased lean body mass and total water. Water-soluble drugs are distributed in a smaller volume than in younger adults. Leads to an increased serum concentration of drugs and increased intensity of effects. Lower albumin levels. Decreased protein binding of drugs leads to more free drug circulating and increased intensity of effects. Metabolism. Hepatic metabolism decreases with age, secondary to reduced hepatic blood flow, reduced liver size, and decreased activity of hepatic enzymes. The worse the liver function, the higher the increase in the drug half-life time and a prolonged response. Response to drugs that go through the first pass metabolism may be enhanced. The degree of drug metabolism varies hugely between individuals. It is hard to predict if and what drug responses will be affected. Excretion. Renal function declines means renal drug excretion declines. Drug accumulation secondary to reduced renal excretion is the most important cause of adverse drug reactions in the elderly. Again, drug accumulation secondary to reduced renal excretion is the most important cause of adverse drug reactions in the elderly. The reduced GFR, renal blood flow, number of nephrons, active tubular secretion, and the degree of renal decline varies between people greatly. Renal function should be assessed with creatinine clearance levels, not the serum creatinine. Categories of drugs during pregnancy with prescribing implications. Category A, a reduced risk, remote risk of fetal harm, least dangerous. Controlled substances in women fail to show risk during the first trimester. No evidence for risk further. Category B, slightly more than A. No risk animal studies, but no women studies have been done, or animal studies show a risk, but controlled studies in women have not shown a risk in the first trimester, and there is no evidence of harm in the second or third trimester. Category C, greater risk than B. Animal studies show a risk, no studies done in women, or no studies done in women or animals. Category D, proven risk of fetal harm. Studies in women show proof of fetal damage, but potential benefit may outweigh the risk. For example, a life-saving illness with no safe or drug effective that would show warning on the med label. Category X, proven risk of fetal harm. Studies in women or animals show a definite fetal abnormality or adverse reaction in reports and evidence of fetal risk. The risks outweigh the benefits. Will show contraindicated on the med label. General prescribing implications from Let's Talk. Choose drugs with the most reassuring safety profile. Choose drugs that have been used and studied for the longest period of time. Prescribe the lowest effective dose for the shortest period of time. When possible, use a single medication as opposed to a combination of products. Weigh the risk versus the benefits and include the patient in the decision-making process. If possible, do not prescribe drugs during the first trimester. Note that some medications are contraindicated during the third trimester due to effects on the neonate. When appropriate, prescribe topical instead of systemic drugs. For maternal conditions, prescribe medication that won't harm the fetus. If the woman is already taking a medication, discontinue only if safe to do so. If her condition necessitates pharmacologic treatment and the medication has known unacceptable fetal risk, discontinue the medication and prescribe a safe alternative. When the fetus or other pregnancy-related sites need treatment, provide medication that will effectively transfer to those areas. For example, the uterus. Example, antibiotics specific to the pathogens that cause endometritis. Fetal placental membranes. Example, antibiotics specific to those membranes causing infection during preterm premature rupture of the membranes. The fetus. Example, antibiotics to protect the fetus from group GBS strep. Elements for a complete prescription. Full name and street address of the patient. Name, street address, and birth date. Depending on the state law, other information to include may be the license number and DEA registration number of the prescriber and name of the collaborating physician. Date of issuance, name, strength, dosage form, and quantity of drug prescribed. You need the number of pills for frequency prescribed. Directions for use. Refills authorized. Prescriber signature. Additional terms from Unit B. Absorption. The movement of a drug from its site of administration into the blood. Efficacy. Maximal efficacy is the largest effect a drug can have. Efficacy is indicated by the height of the dose-response curve. It's an important quality. Excretion. Movement of drugs and their metabolites out of the body. Hepatotoxicity. Drugs leading cause of acute liver failure. When drugs are metabolized in the liver, they can be converted to products that harm the liver. Monitor LFTs if the drug is hepatotoxic. Pharmacodynamics. Biochemical and physiologic effects of drugs and molecular mechanisms by which the effects are produced, i.e., what drugs do to the body and how they do it. Pharmacokinetics. Drug movement throughout the body. Includes absorption, distribution, metabolism, and elimination. Steady state. Either during continuous IV infusion or regular dosing, drug levels until they reach a plateau area and remain at that steady state. Synergist. Two or more drugs act together at the same time, so the total effect of the combined drug is larger than the sum of each drug when taken independently. For example, alcohol and Tylenol.